Lovely. Well, as is our best practice, it is now time for a roughly 30-minute discussion on these two presentations only, and then we'll go around and ask Roundtable members to deliver your 1 or 2 or 3 or 4 if they're really concise key points, and then we'll hopefully at least double the level of audience participation in the day as we go through this. So questions for these speakers? Cindy.
Cindy Brock with the Agency for Healthcare Research and Quality. Chuck, I really like one of your last points here about the market, and I'm wondering if you have any ideas. You know, we have the lone Mark Williams petitioning the EHR vendors, please help me do this. What can we do to stimulate that market demand to try and get more patient-centric ABSs and discharge instructions?
Yeah, and the issue becomes, is this a regulation or is there some other lever to make it work? When I was talking to a lot of the retail pharmacies, they say it's going to be really hard for the first pharmacy to do something. But once that first one does something, then the others will follow. And you know, if you think about the medication instruction and think about Chinatown, if you have a block with 2 pharmacies, and one provides instructions in the patient's language. What the patients told me was that they would actually recommend that pharmacy to their friends and family because they were addressing the needs. So I think there is a business angle here, and with the ACOs and PCMHs, you know, keeping people healthy and making sure that the patients are taking their medications on time is a business proposition, and I think that's probably a bigger trend for them to actually act on this rather than a regulation.
Well, I think Mark mentioned earlier. Mike, it's just the issue of value-based purchasing, and I think 30% of your VBP score is going to be on satisfaction. So, in a way, the part of this will happen at the market competing at the high end, even though it's not exactly what you'd expect. That people who are going to in catchment areas where hospitals need to compete or systems need to compete on satisfaction, then maybe we'll see that drive first. But this also has to be driven by mission. So you know that's part of the problem is to see where there's a connection between mission and you know, but no margin, no mission. So it's got to actually make monetary sense in the end too. I don't know if the low English proficiency part of the market may not be big enough from the provider side, but it might be huge at the pharmacy level. So all these things need to be vetted out. But I agree that there could be a tipping point. It doesn't need to take so many in a given catchment area for people to say, oh, we need to be doing this too. And with so much consolidation in the EMR space, it might not take such a big thing.
Thanks. Let's go. Lori, George, then Bernie.
I actually just wanted to post, I think actually that it would be a wonderful thing in my mind to invite Walgreens or CVS to the table here. And I think now is the right time. You have Will Schrank at CVS now, who's just a big believer in health literacy. And I've mentioned this to a few of you. We've been funding, Mike Wolf and Ruth Parker are working with Northwestern and Emory. We're working with the Alliance of Chicago Federally Qualified Health Centers and with Walgreens to implement the UMS, essentially in standard SIGs at both the point of prescribing as well as the point of dispensing. So if you take one tablet once a day, right, and this is, I'm borrowing from Mike Wolf here, but 57 different ways in one practice and written 27 different ways at the pharmacy. And most importantly, the themes I've heard here is we're not adding workflow. So we're pre-populating EMRs, and we're trying to think about, not running over into, readability, in short. So I really do believe that adding Walgreens or CVS to this conversation could potentially help benefits.
You want to introduce yourself to Lori?
Oh, sorry. Laurie Myers, and I have the privilege of leading health literacy strategy at Merck. So I've only been a part of this conversation for 3 years, but I'm honored to be here, and thank you very much.
Great. Comment, response at all from either of you?
That's right. Do it.
There you go.
I agree.
Exactly. All right, George.
Yeah, George Isham, Health Partners. So I was so glad to see the layout of the medication summary that you described, Michael, and also the cultural sort of adaptation of that same 4 times a day layout that we heard about, some time ago here at the Roundtable. 2 questions. One, what happens when that's changed after the patient goes home? When it's discontinued or the frequency is adjusted and so forth, how does it become sort of a living tool or resource for the patient? So that's one question. And then my second question is, having managed these medications for family members, at home, is how does it get integrated with your physical need to actually manage the pills and lay them out? There are those little bin systems that people have by day and time. And is there a further integration into how you help the patient actually manage the tablets themselves out of the pills? What do you tell them, or is there a way of looking at this? So 2 questions.
Yeah, so one of the challenges when I was talking to residents doing intake, and they said they spend about 30 minutes to an hour making sure that the patient's medication list is up to date. So the intake process would be much simpler if they came in with a list of all their medicines up to date. So the other challenge is that there are patients on disparate health systems, so the primary care provider is not necessarily may not be an issue with health partners, but in the rest of the country, it could be an issue. So our system is designed to be portable. That is that if you have the medication list record ID, the primary care provider can go in there and make updates after they see the patient and give them an updated list at the end of the visit. If we had a patient portal, the patient themselves could add multivitamins or over-the-counter meds that they're taking. So if you did it for your parents, then you could keep that updated. So when the patient went back into the hospital, the intake staff would have the most current list of medications, and that would be something I think would benefit a lot of folks.
There's a lot of issues of how to take this and make it into a live concept. It has to be something, it really should. Today we focused really on what does it look like in a way, but the data has to be able to flow. So it's actually incredibly frustrating that it doesn't flow nearly as well as it should be flowing. But so it should go to your personal health record. It should go to all your providers, and any updates that get made should get updated to there. And there's so many problems between here and there. For example, a lot of my patients, I don't know what they have to pay actually out of pocket when I prescribe for them. That's crazy. The pharmacist knows how they have to pay, so that has to be fixed. And I prescribe, and I don't know that they actually obtained the medicine or not. That has to be fixed too. So these documents have to be like live. And right now, the healthcare system isn't really a great consumer of that. If the patient starts to give all this information all the time, the doctors are going to start tearing their hair out even more. So we have to figure out how, so maybe the ACO and the medical home is the promise for this to actually be a live experience. But certainly, one bet is, even though it was, worries about IT, that has to be the future. There's no way around it. Many of my patients don't have smartphones yet, but it will happen eventually, probably. I give my email address to almost all my patients at Boston Medical Center. It's very easy because so few of them use email. Because so there's a big digital divide. So there's so many problems, but it has to be live. It's just a matter of designing for the future right now.
Yes, Charles, that was a very wonderful, very clear presentation. I love the concept of challenges and moving those challenges to opportunities, which you really, articulated quite well. As we look at outcomes secondary to these multiple efforts, intuitively we would think and we would say that hospital admissions and readmissions would be probably impacted successfully by these efforts. Any studies looking at this either currently or in the future? It would be
Yeah, actually, UConn looked at the readmission rate and actually went down. I don't know the specifics, but they did look at that. And these, the three studies that I mentioned were all pilot studies. I know the Durham VA, the first batch was 23 patients. They're looking at another follow-on study with over 300 patients. So this was a preliminary, but in terms of, from my perspective, this is just common sense that we should try some of these things and figure out whether they work or not. And to get to the point about whether the LEP population could benefit from this, we don't pitch this as an LEP product. We pitch this as a health literacy, adherence, medication safety product, which can be used by everybody. And then we say, oh, by the way, this is also available in 19 languages. So there's no rationale for them to think this is only for my LEP patients. So I think that's one of the messages that we need to make sure that goes out there.
I certainly didn't mean to denigrate the LEP agenda. We did some work with the after hospital care plans in Spanish and also in Mandarin, in Chinese languages. But there's loads of work to be done, and it's very important work. But does everything need a randomized controlled trial? That's really the part of the problem right now, is that this care transition space has had some decent trials. I was really lucky enough to be kind of at the spot when those were still being funded. And it's actually harder. That was like 8 years ago that was funded. It's actually really hard to get these trials funded now, partially because people are hungry for change to already happen and not actually have everything get litigated in an RCT. There are other designs that could be evaluated. I have a grant in to look at automated phone calls in English and Spanish to reinforce the after-visit summary. So if you have a new medication written at discharge with Mike and same cast of characters, people, and we'll see if it works. But I wouldn't be surprised if people looked at that and said, "You want to do a trial? Come on, just make it already, and we won't fund you for that trial."
Yeah, I wouldn't do an RCT on this, but there are other efforts to get the information. I think would just be helpful in the funding and also in bringing it to the forefront as something that is really worthwhile and really somewhat effortless. I mean, in terms of getting the data.
All right, Bernard.
I just want to make two brief comments and then ask Michael a question. So my first brief comment is we've been having this smartphone saturation conversation. And so I've been thinking about that. And I realized that, of course, my patients, the parents of my patients or my patients are all young. So I have a few grandparents that we deal with, but mostly it's parents. And so probably smartphone saturation is much higher in that age group as opposed to internal medicine level patients. The other comment is I'm happy to see that Cindy actually got Michael into a 12-step program from an 11-step program. So, and
This is being recorded, by the way.
My name is Michael Pashor, though.
Yeah.
Thank you.
Which Michael? Yeah, you actually. Yes, this is yes. And I am a health literacy researcher. Okay. So my question to Michael is, of those 12 steps, which are what do we know about which are the most important? I mean, I was thinking, for example, one of the things I mentioned, and I mentioned it partly because I know you're doing it, is this calling the patient after discharge. So how do we decide which of those 12 steps, or what do we know about it? I don't know if we have to decide anything. What do we know about the relative importance of those things?
Yeah, this is a great question. I don't know the answer. We didn't have a way to differentiate the relative effects of the different components of it. I think in the end, the project kind of looks very much like an amalgam of Brian Jack's work in patient safety and my work in health literacy, and that really this is an amalgam there because like some of the steps are very much out of safety and very much out of organization care on the clinician side, and some of them are very much on the patient education side. So I like to think that my little niche is relevant, but if we can't differentiate very well. We can see that something like a change occurs whereby something on the order of 8 minutes, that's what Mark's data was, like about 8 minutes per discharge, changes to something like 45, 50 minutes in terms of actually sitting and having face time with the patient and family to teach and confirm comprehension. That looks like a change in process, and it looks like something that seems worthwhile. Also, we can say about the follow-up phone calls, it seems like that's very important because even people who get the whole intervention half the time still have something to deal with on their phone, on the phone call relating to the medication, which means that there's so much complexity in that space. Something on the order of 30% of the prescriptions written at discharge are still not obtained by the time you make that phone call, at least in our population. So that means there's a lot of room for scope for improvement there. So, you know, it means I'm going to vote for that post-discharge follow-up, including comments from Darren about cognitive impairment and all that kind of stuff. So that seems like something worthwhile, probably after outpatient visits too. You know, you have a new medicine that you, or out of the ED, you know, you prescribe a medication out of the ED, maybe, you know, give them a call and see if they're going to do that. Or if they're, you know, maybe they're in somebody else's ED now, so because they never got the medicine for asthma.
Just an anecdote. We've evaluated in our asthma program what the problems are in you know, using preventive steroid inhalers, and the major problem is that they never fill the prescription for a variety of reasons. So.
Lori?
Thanks to both of you. Those are really interesting and I think complemented what we've heard the rest of today. Just a couple thoughts and then a question. Medication management is one of those sort of areas it's been somewhat studied, and I know in Oregon with the ACO, CCO world, cost is such a driver, and we're really looking at how to adjust, help adherence, work with polypharmacy, and the role of nurses in that. And so I can imagine you guys are looking at that as well. One thing that I'd heard a while ago, and I'm curious if you know this, when patients have the ability to interact with their med record online, apparently their medications, they're far more honest because they don't worry about disappointing the physician with the way they're actually taking it. And I had heard that years ago, that to have, here's how it's prescribed and here's how I take it, and to do it electronically. Are you guys looking at that, or have you seen that?
So I haven't done that kind of work online. The way I do that kind of work is with a different type of system that I didn't talk about yet today, which is that I've had the pleasure to design, create, and evaluate avatar systems. We call them embodied conversational agents. And our embodied conversational agents do seem to elicit different information than is elicited to a human in various contexts. In a recent study, for example, about taking family histories compared to the gold standard, which was an interview from a genetic counselor, there was much more communication about drug addiction and alcoholism in the family than to the genetic counselor because it was a computer. Or at least it supports that same line. And we've done similar things with adherence, where we were looking post-discharge, we were interacting with the system. But I think there's a lot of context, and almost anything that you think of that could be stigmatizing, which is almost anything, is something to think about where you could reinforce the data collection with the electronic systems.
And also, the patients really appreciate being asked to participate and filling out things that might be missing. And I think one of the frustrations is that a lot of these patient portals, if they see incorrect information but they can't change it, there's a lot of frustration with that as well. So you just got to be very sensitive to making sure that you get that input, but allow the ability to incorporate their feedback into your system.
This right on this point? Okay.
This issue of about patients or people being more likely to be frank about possibly embarrassing or whatever to a computer has been reliably tested and tested and tested. And you know, I think the original studies were done by Warner Slack in the late 60s or early 70s in terms of people filling things out in the anteroom or doing something that they wouldn't tell a person. And it seems to have survived through every evolution of much easier devices on which to do it. So I think it is just something that I think everyone who is trying to elicit information from patients or from the general public should be aware of.
All right. Do you want to comment on?
Well, just I think that's also how to use that insight into like so for the PHRs. One of the questions here, really, I think that people have to think about is why is nobody using my PHR? Like so like who wants to use your damn app anyway? So that's really part of the issue. And one of the places where you can is to when you can engage and have the interaction, or that they can add value there.
I think that really it gets to Dr. Lee's comment and what other people are interested that the doctor has the right information. Maybe they're less embarrassed to tell the computer in some sense than they are to tell the nurse or the clinical whatever. And then the issue is, if I'm just creating my PHR, is anyone going to use this? Which I think is a totally different, I mean, I think it's a different dynamic as opposed to I want my provider to have the best information and I want to be able to fix it and update it for them. I mean, I think there are two things going on there.
Yeah, and there's also how the information is going to be used. So you're not going to be looking at your PHR every day, but you could be looking at your medication list every day. And a lot of times patients who get access to PHR don't use it because they forgot their ID and password. So making sure that there's a rationale behind why that you want the patient engaged and they feel valued in providing feedback is something that's really important.
We have no information on what is the optimum frequency with which patients should be using information. If they don't understand their medications and they don't have a system in front of them, yes, we want them to do that every day. But the rest of this information, I have access to my information, and guess when I look at it, hey, if I have a test, I go to look at the result. If I have 2 tests a year, it'll be twice a year that I look at it.
One of the themes that has come up is how the providers just either don't want the extra burden, and I've done a few projects where I've asked them how frequently would they like extracts from patients' data or here or there, and the most common answer that I get is how about never? Never. How about never? And so because it really is so much work all the time, and they feel beaten down. So we have a project that's going to come out soonish. Bill Adams is the first author. It's a pediatric-based comment. That's why I'm looking at you. It's a pediatric project where before the appointment there was an automatic IVR system to ask screening questions. It goes into PHR if it wants, but really it pops up onto the screen when the PCP is opening the clinic note, and so it's in the workflow that the information comes there. And this is the first one where I really saw that the clinicians loved it. The clinicians really loved it. It saved them keystrokes. They were like, I can upcode my note here. I go like this, click, and 100 keystrokes go in, and then they also get the screening data out of it. So figuring out how this works into the workflow is a big, complicated part of the puzzle.
All right, let's go Wilma and then George. And if anyone from the audience wants to ask a question, quickly make your way around to that microphone.
Wilma Alvarado Little, UAlbany SUNY. One, I want to thank Dr. Lee for his comment. Non-English is not just Spanish. Thank you so much. My question to you is regarding the 19 languages that you have included. In New York State, Governor Cuomo signed Executive Order number 26, which mandates all state agencies are required to provide language access services in the top 6 languages as identified by U.S. Census 2010, which is fine, right? So what thoughts or consideration are there for additional languages as the demographics of the U.S. changes? And not only I would say, a growth of other languages, but an awareness and or acknowledgement that there are other languages being utilized in various communities. And I don't know if maybe it's too nuanced to ask about some of the languages of limited or lesser diffusion, but just what I would like to hear your thoughts on that.
Yeah, so one of the issues is that the most bang for the buck comes from patients who have limited English proficiency, which means that if they speak English very well, then it's less of as an urgent issue. For instance, there's a lot of German speakers in the United States, but they tend to speak English very well. So it's we noticed this with pockets. So if you, like Chinatown, whether there's someone isolated, or the Hmong population, where they're somewhat isolated, they have more of an issue with understanding the English language. We did look at the regulations from New York State, and we do comply with all of the ones that were mandated. Some of them didn't make much sense, but we did it anyways. But then we approached upstate New York, and they had an issue with Karen and Swahili and Burmese, so we developed those languages for them. So it needs to be market driven. So when we talk to people in Los Angeles and they have an issue with Farsi, we'll develop Farsi. If they have an issue with Tagalog, we'll develop Tagalog. But it's going to be very resource driven by the market. But that being said, one of our market goals is that if we develop a language for any customers, it becomes instantly available for every other customer. There's no reason to withhold some of these languages just to get different pricing levels, which your business person might want to try to do, Lori. But it needs to be focused on sharing and being able to develop these things and repurposing these types of resources.
Just to reinforce, I think the market really speaks about these things. So totally different topic of my work. I've developed a series with colleagues of video decision aids about end-of-life decision-making and started a nonprofit in this space. And really, whichever partners we get to help us create the next language is what happens. So we have, HMSA in Hawaii has now helped us make Japanese and Tagalog and Ilocano. We wouldn't have gotten to Ilocano before without a partner in Hawaii, but because we're in Hawaii, that's like the 6th language in Hawaii, and so we got to it, and we already have Spanish, and so we have a partner in Kaiser in California, so we have Chinese languages. So it's really crazy that it takes that, but it does take that sometimes. Even just a little bit of money can force the issue. And of course, once it's available, once you create the resource, then it has to be available to everyone anywhere. But it's embarrassing.
George.
Yeah, thanks for a second question since I missed most of the day. And so the question may have been answered earlier in the day too. So I apologize if this has been addressed before I came. So as I look through the handouts that we have for the day, I see some examples of medication lists spread throughout these handouts. And I see some of them deal with pain medications, some of the examples in our folder here. And I see at least one hydrocodone and acetaminophen example. And in one of the summaries, I see another one where it's been labeled, don't take more than 3,000 milligrams a day. I see another sample, another summary here where there's morphine sulfate tablets. And it's not really apparent from the diagnoses associated with that, why the person's taking that. So with a complex issue like pain relief and the potential for the abuse of pain medications, or the unintentional habituation that can sometimes occur. How do you deal with that kind of concept or that kind of challenge in a discharge instruction where you're dealing with a low literacy population and or in particular, your very compelling examples of dealing with people in entirely different languages? How do you deal with that in these kinds of instructions? My personal experience with the Tylenol issue is that it's somewhat complex if you're being aggressive in terms of using over-the-counter acetaminophen in combination, trying to manage yourself off of that to manage the limit sometimes when you're dealing with post-operative kind of pain. But so that sets up a complex situation, and I'm asking how your systems, what kind of advice can you give us about how to be effective in communicating that in this kind of environment?
Yeah, and that brings up the issue of whether it's intentional or unintentional you're looking at. The other issue is around age. So depending on the person's age, if it's a pediatric patient, you may have a different maximum dosage. you can, because these are living customized documents, you can take those into account so that if a person is on multiple medications, in that recommended, this is how you should take it list, we can actually do those kind of calculations and throw up warnings. But the other issue is because these people can be shopping for different providers and they go to different pharmacies and pick up different meds, which this list is not going to address. So we actually have a different tool to do fill history intelligence. We can actually visualize where you picked up which med at which pharmacy. So having that in concert with the patient-facing document is what's really needed to address the issue you raised.
Yeah, this is a very complicated topic, and you could see demonstrations of different approaches in different states even. There have been state efforts. Massachusetts actually has a system that any provider can log on. They have to do a training, blah, blah, blah. There's a barrier, but not everybody's doing it. So, but any provider can log on and see the whole history, all the sites, all the providers, all the dispensers for any opiates. But of course, you know, you can go over the state line, and not all the states are using this kinds of system. But there's multiple levels how to answer this question. Just with the acetaminophen, of course, it can be extremely complicated because of over-the-counters and the mix, and there's so many products that have acetaminophen. And I know that's a topic that's been addressed by the Roundtable. You know, and there's really evolving standards of care for how much scrutiny is appropriate for opiates. And there's also loads of people who are treated for their pain. So it's quite complicated. I see a pattern with my patients that they take their prescribed medications kind of like PRNs, and their PRNs kind of like on a regimen when it comes to opiates. So that's like one hint, you know. Oh, I take that every 8 hours, exactly like it's written. How about the other ones? Oh, I don't know. You know, so you have to talk with the patients in the end. So there's only so much the form can do. It's going to have to be an interactive process to see, is this a person who's at risk for diversion? Is this a person who's at risk for undermanagement of their symptoms? And the whole gamut in between. And, you know, so at Boston Medical Center, we have the full gamut. So most of my patients are, you know, having pill counts by a nurse and having urine testing as well, because we have a major diversion issue, you know, in our institution. But I'm sure there are other institutions that's not the nature of the problem. I love this topic, but I'll stop.
Yeah, and also, remember I was saying before that you could have a QR code for demonstrations of complex medicines. You could easily have the same thing for patients who are taking any acetaminophen medications. Have a little demonstration of acetaminophen warning in the person's language. That's easy to do.
And more tools in the pharmacies. You know, there's a lot of growth potential for, you know, there's so much complexity in the pharmacy. Over-the-counter thing has a lot of room for improvement. Tools there too.
All right, let's thank these speakers.